participate on this amazing conference. We will discuss therapeutic advances in bariatric endoscopy. So this is my disclosure. So when you talk about obesity and the metabolic conditions associated with the obesity, we know that diet and physical activities and also medications has not a long-term follow-up satisfactory results. Bariatric surgery is the best approach for obesity and metabolic diseases. However, it's the most invasive one. So as you can see in this image, there is a gap between the conservative measures and the bariatric surgery. And this gap should be filled with endoscopic bariatric and metabolic therapies. And we're going to talk about this during this presentation. So when you talk about endoscopic and bariatric and metabolic therapies, we talk about stomach and small bowel therapies. So most therapies related to the stomach are associated with a great weight loss. And the therapies associated with the small bowel as usually improves diabetes and other metabolic conditions. We will discuss all types of procedures. So the most traditional endoscopic device for obesity is the intragastric balloons. There are several types, and the new intragastric balloons is the swallowable balloon. So we have two types of swallowable balloons. The one filled with air and the other one filled with fluid. So the air balloon, you will swallow the capsule, and then you have a navigation system to see if it's inside the stomach. Then you inflate the balloon with nitrogen, and you can place until 3 balloons. However, to remove these balloons, you do need endoscopy. The fluid balloon, you're gonna swallow the capsule, you're gonna fill with 400 cc's of fluid, and then there is a valve that is degradable, and then you don't need to remove by endoscopy. You're gonna evacuate the balloon. So the one with thought endoscopy is the fluid balloon, named ellipse balloon. So these are two meta-analyses based on randomized control trials performed by our group, and both showed that intragastric balloon is effective in promoting weight loss in short and mid-term follow-up. The first one is just with fluid balloons, and the second one, we included all types of balloons, as you can see. So now we'll discuss gastric remodeling. So these new devices, you can do a full thickness suturing or a full thickness plication. Then you're gonna have the seroso apposition. So we're gonna start with endoscopic sleeve gastroplasty. This is the most performant procedure nowadays. And the technique evolved during the years. So first it was performed in the luminal vertical gastroplasty in the anterior wall. And nowadays we do focus on the greater curvature on the body of the stomach. And then you can see in the video a full thickness bite. The mechanism of action of the ESG is related to gastric size reduction in both width and length. It is associated also with a delayed gastric empty, and this is going to cause sacite alteration. So that's the mechanism of action of ESG. These are the results. You can see there are, in this meta-analysis also performed by our group, you can see several centers from different continents, and this is what you see. There is it's a very reproducible procedure. So in all centers you have similar results. And the mean weight, total weight loss is 16% at 18 months follow-up. Now we're going to talk about the pose. The pose is the application device. So the pose one was performed focused on the fundus and the distal body. And then we did have some good results in Europe. You can see in this meta-analysis performed by our group, a total weight loss of 12%. However, during the US trial, the results were very bad, and then they modified the technique for the pose 2. The pose 2, it's application focused on the gastric body, on the greater curvature. And in this study from Gonzalo Navas, you can see almost 18% total weight loss, very similar to the endoscopic sleeve gastroplasty. So Endomina is another application device. You can see you grab the tissue, you bring inside this tower, and then you're gonna pass the suture. The technique is a little bit different from the pose 2, and the results are interesting. You can see a total body weight loss at 1 year of 12%, a little bit lower than the ESG and the pose 2. The endozip is another suturing device. This is an automatic suturing device. So you're gonna place this device inside the stomach, and then you're gonna have this needle, which gonna do a mechanical suturing, also a full thickness suturing. And the results at 6 months follow-up were quite interesting, a 16% total weight loss. The device is having some modifications for the next generation, but I think soon we're gonna have this available in the marketing. Aspiration therapy, this is a device that some people have some concerns. You do like a gastrostomy and place a large tube, and then after the meal, the patient can remove part of the food. So, but before you say this is bulimia and say you don't like it, try to understand the mechanism of action of the device. So there is a caloric reduction of just 30%. So the patient really needs to improve his eating behavior. So he needs to slow chewing, he needs to drink more water, and to do regular meals, because you're gonna use the device just 3 times a day. And of course, the patient gonna think before eating, because when you watch this video, you see it's really quite disgusting. So the patient think about eating or not. Transpyloric shuttle is also a new device. This is kind of a balloon. So you have 2 balloons, one is small cylinder and the other a balloon filled with silicone. And the mechanism of action is the intermittent pyloric obstruction. So you have the big balloon never crosses the pylorus, and then you're gonna have this intermittent obstruction, and you're gonna have a delay in gastric emptying. So it's an interesting new device. Total body weight loss is similar to the conventional balloon, 9.5%. So this is similar to the Aspire. It's also approved by the FDA. Now we're going to talk about small bowel therapies. So to understand these procedures, you need to understand the foregut and high gut hypothesis. So in this video, you can see the normal anatomy. So in the duodenum, you can see there are several cells which produces the anti-incretin effective, which is an unknown factor. And then you also have the cells producing the incretins, with, for example, GLP-1 and other hormones such as PPY. So when you ablate or you exclude the duodenum, you won't have the anti-incretin factor. And when the foods goes faster to the distal small bowel, you're gonna have an improvement in GLP-1 and other hormones, and then you're gonna have an improved insulin response. So this is the mechanism of action that you need to understand: the foregut and the hindgut hypothesis. So when you talk about the endobarium, we have both the foregut and the hindgut effect. So you're gonna exclude the duodenum with a liner. See, you have a metal stent to fix in the bulb, some barbs, and then you have the liner excluding the duodenum and the proximal jejunum. The results were very interesting. We did this trial in Brazil, and we have a total body weight loss of 16% and HbA1c reduction of 2.3%. 72% of patients had diabetes control. So this device has just one problem: this fixation. So we had a lot of migrations, we had also perforations, and the most concern is liver abscess. Now the company is giving giving PPIs for patients, and they are in a new trial in the US to get FDA approved. So let's wait for the results. I really like this device. Duodeноmucosal resurface, we also did this trial in our hospital, the international trial. And the mechanism of action is just the foregut, the foregut effect. So we do the ablation of the duodenum to decrease the anti-incretin's role in the proximal small bowel. And the rationale is to provide the formation of new enterocytes and reestablish a healthy neuroendocrine axis. So you burn the mucosa, and you're gonna have a new mucosa soon, and then you can have the benefits of this procedure. It's quite interesting approach. We also did a meta-analysis evaluating the duodenomucosal resurface, and what you see is that this approach presents promising results in terms of diabetes control and improvement in liver function, despite its low efficacy in terms of weight loss. Partial jejunal diversion, this is also a very interesting approach. So you have two pediatric colonoscopes, one you go to the mouth and the other through the anus. Then you place it one in the proximal jejunal and one in the distal ileal. You put together, and then after 6 days, you're gonna have the anastomosis. So it's a jejunal ileal anastomosis. And the first results in humans were very, very promising. A total body weight loss of 14% and a reduction in HbA1 in all diabetic patients. So it's really, really interesting approach. The problem of this procedure is quite hard to do by just by endoscopy, and laparoscopic assistance is required. So this is what we have now. And this is the Oxford system for grading level of evidence of this procedure. So as you can see, we do have a lot of meta-analysis with randomized control trials. We do have randomized control trials. And so the data is good. So we need to trust these devices. We have data proving it. However, we do need to have long-term studies. So all these studies has a short-term follow-up. So now let's talk about the future of endoscopic bariatric and metabolic therapies. We do have more 5 minutes, so let's try to talk about it. We're going to discuss novel devices and techniques and combination therapies. So this is the full sense device, as you can see in the video. This is a society signing device. So they stand, when it's placed, it makes a pressure on the distal esophagus, cardia, and fundus, and then it will induce satiety and fullness based on neurohormonal signs, even in a fasted state. So the patient doesn't need to eat to feel satiety. So this device is quite interesting. I have some concerns about migration, but the company is working on that. And I think soon we will have this device available on marketing. So these are other devices. Some of them were, all of them were tried in humans. So these are the endoscopic bypass. Most of them are similar to the endoberry, but with different fixations. So metabolics, you have this stem, viscera, you have a larger one coming to the antrum. And the Valentex, it's a little bit different because you have the esophageal, you place it on the esophagus, so you bypass the stomach and the duodenum and the proximal jejunum. So it's a more larger sleeve, and all of these procedures are very effective in terms of weight loss and diabetes control. However, they are associated with a low safety profile. As I said, with endoberry, these are stents, and we know it's hard to fix it then in the upper GI tract. So ablation therapies, it's quite similar to the duodenomucosal resurface. However, the diagonal, it's with a laser, and the electroporation, you not burn just the mucosa, but also the submucosa. And we expect similar results to the duodenomucosal resurface. So some studies are being done, but there is no human trials yet. Gastric mucosal digitalization. This is an interesting technique described by Vivek Kumbhari. So he observed that increased insulin secretion and improved insulin sensitive were seen in diabetic patients immediately after sleeve gastrectomy, even before any weight loss. So based on that, he thought that the gastric mucosa secretes oxygenic and anoxygenic hormones, making it a complex regulator of food intake as well as glucose and lipid metabolism. So that's why he want to burn the mucosa, and he did that in pigs and rats, and these are the results in pigs. So when you do gastric mucosal digitalization, you have a better result in the sham group, however, not as good as the sleeve. You can see the analysis related to weight loss, related to visceral adipose tissue, and also a hormonal alteration such as an unsulated ghrelin. This is another new device, a very interesting one. This is a balloon placed similar to a stent. So you deploy a balloon, and inside it has a magnet, and you have an external magnet, and then you can move the balloon inside your stomach, and you're going to stimulate the gastric wall and the neurohormones. So you should do that 5 to 10 minutes, and you also can observe in this machine how is your glucose level, your hunger level, And also you can observe the balloon inside to facilitate diet and behavior modification. So it's an interesting device. Endoscopic robotic suturing. So we do not have platforms that goes to the stomach to perform suturing yet, but there are some companies working on that, and I do think this is the future of bariatric endoscopy. We're gonna do full thickness suturing with a 2 arms robot. And this is another device, the sleeve balloon device. You have an intragastric balloon, and you have the liner as well. So see this GI contrast GI series. You have the similar effect of the coronary gastric bypass. So the food will goes direct through the proximal jejunum. So you're gonna avoid duodenum, and then you're gonna have the hindgut effective. But you also, with the balloon, the sleeve balloon, you're also gonna have the effects in the fundus. You're gonna have a delaying gastric empty, and you're also gonna have the fundus different from the bypass. So this may be a benefit of this device. This study was performed just in rats, but the results are very encouraging. So the sleeve balloons reduce peripheral and hepatic insulin resistant glycemia, body weight, and ectopic fat deposition to a similar level as coronary gastric bypass, although the contribution of gastric emptying to blood glucose reduction is different. So this is a very interesting approach, and see the graphic, it's really similar to coronary gastric bypass. Let's see how this is going to work in humans. So combining therapies, you can combine two metabolic procedure, endoscopic bariatric and metabolic procedure, such as balloon and endoberry, and you're going to have an enhanced in weight loss and metabolic outcomes as shown by Bahram group. And finally, to finish this presentation, we're going to talk about combining an endoscopic procedure with medication, such as liraglutide. So this study comparing ESG plus liraglutide versus ESG. And what you have is when you use liraglutide, you have an increase in weight loss. So you can achieve almost 25% total body weight loss at 1 year follow-up. So it's a really interesting study, almost similar to sleeve. So my take-home messages are the GI tract plays an important role in weight and metabolic regulation. Endoscopic bariatric and metabolic therapy is in constant development, including devices with a wide variety of mechanisms of actions, and I am sure it will play a major role in the management of obesity and its metabolic complications. And we need to know that personalized approach, combining therapies, and a multidisciplinary approach are keys to success. So I want to thank you very much for your attention, and I wanted to invite you for the second bariatric endoscopy live global. This is a course when we perform all these procedures that we showed to you in 14 centers of excellence. It will be live procedures, and the registration is free at the website. So please join us on October 1st. Thank you so much for your attention.